Hi there. I wasn't able to make it to your class today to do the debriefing on your exam on the kinetics portion of the second endocrine exam, so I am going to do it this way. I hope you like it. That way you can go back and look at it if you need to for the final. And obviously, if you need to ask me questions, you can come in anytime. But this is to go over the exam questions from the second endocrine exam from spring of 2012. So the first question was, you are the pharmacist in a warfarin clinic. Your patient, Mrs. Snyder, comes to you looking like this. Obviously, she's got some exothalamus, and that's very diagnostic of hyperthyroidism, since that's what we're talking about. So we're going to assume she has some hyperthyroidism. Would you expect that she will need a higher, lower, or no change in the dose of her warfarin because of this? Well, if you recall, it's a little bit confusing because you don't necessarily want to think so much about the warfarin as you do about the vitamin K dependent clotting factors here. And the vitamin K dependent clotting factors, both the synthesis and the clearance are sped up in a hyperthyroid patient because remember, they're hypermetabolic. So both these things are occurring. But what's more important is the increase in clearance of those vitamin K dependent clotting factors. So if you have a increase in clearance of the vitamin K dependent clotting factors, then you are going to see, well, I can use you have an increase in the clearance of the vitamin K dependent clotting factors. Oh, I can use a pen, which will be better than the mouse. You're going to see a decrease in the concentration of the vitamin K dependent clotting factors. Therefore, you're going to have a lesser, where will that go down here? A lesser need for your warfarin. So you need a lower warfarin dose. So you're going to expect to decrease your warfarin dose. And I have included here the slide that talks about this. So in hyperthyroidism, you have both your synthesis and clearance of vitamin K. I'm not getting used to this. Dependent clotting factors are increased, but the catabolism or the clearance outweighs the increase in the synthesis. Therefore, you need a lower dose of warfarin. So you needed to say both that you needed a lower dose of warfarin and that the increase in clearance of vitamin K dependent clotting factors was Y to get your full points there. The next question was to relate to that question, and so in general, in this same patient, what general pharmacokinetic changes would you expect to see in other drugs? Well, what's happening, we know in hyperthyroid patient is an increase in all their metabolic activity. So the big things we're going to see is an increase in cardiac output, increase in GFR, and all of these things would relate to an increase, I don't know how to do this, in clearance. So yes, we would expect an increase in clearance because of all this increase in in blood flows for some drugs. Drugs that are cleared renally, drugs that are cleared hepatically, that are high extraction drugs, you would definitely see an increase in clearance. Okay, would you expect to see an increase in or a change in volume and distribution? Well, volume and distribution, remember, is all about binding, isn't it? Now, if you said something intelligent like there would be a decrease in proteins because of an increase in clearance of them or something that made sense, I gave you credit for that. But if you said something that didn't make any sense, I would say there's probably not going to be a big change in volume distribution because the only thing that's really changing is all these blood flows. If some people said they would lose weight and have less fat stores, well, I suppose for drugs that are highly bound to fat tissues, the volume of distribution would decrease. If you said something intelligent, I gave you credit. If I couldn't make any sense of it, then you did not get credit. But the best answer here is probably no. Now, change in bioavailability. There was a lot of confusion here, which concerned me, so I want to take a little minute and go through this. Bioavailability is about the fraction of drug that is taken that actually makes it to the bloodstream. So if you're giving something IV, the bioavailability will always be 1. If you're giving something orally, first the drug has to be absorbed, then it has to make it through the gut wall without being metabolized or transported back into the gut wall, and then finally it has to make it through the liver. So all of these things need to occur to give you your bioavailability. Maybe that's why it's so crooked. So we have to think about all of these things. Now, a lot of you guys said something about protein binding with bioavailability, which does not really have anything to do with bioavailability. So if that's maybe next time I get to see you guys, we'll spend some time talking about that, because I think there's a lot of people mixed up here. Now, there is the possibility of having an increase, where's my pen now? An increase in blood flow to the gut, or an increase in motility of the gut, which may affect bioavailability. If you said something like that, you should have gotten full credit. But in general, I would expect no change in bioavailability with hyperthyroidism. This goes over I just brought the slides together that showed what changes you would expect to see in hyperthyroidism. Again, it's really blood flow issues, increase in basal metabolic rate. Okay, in hyperthyroidism, we do see that increase in GI motility, which could affect bioavailability. If you said something like that, you should have gotten full credit. Changes in blood flows. Therefore, we usually see increase in clearance, which would cause a decrease in half-life. All right, your Aunt Georgia is tired of paying for her Synthroid, and she wants to switch to another less expensive product. What would you suggest she do? Well, first of all, most of you said you would encourage her not to change, because once you change, you would have to have additional testing to make sure that you're within range for your TSH, which is absolutely true, which may end up being more expensive in the long run. But if she can say, if she's got money problems and you can help her figure out how much money she's actually going to save, you could look for a bioequivalent product. Remember, the thyroid products all had to go through bioequivalency testing recently. So what you can do is pull up our handy dandy little chart here, and let's see, she's starting out with Synthroid. So the things that are equivalent would be Unithroid, Levo-T, or the Mylan generic brand. So what she would want to do is check and see if any of these are on the formulary for her insurance, and if any of these are significantly less expensive than the Synthroid. If you do recommend a change, obviously you would want her to check with her physician and make sure that she's scheduled to have her TSH rechecked in 6 to 8 weeks to make sure that there's no significant change in how much of the drug is bioavailable to her. But in general, it's best if you don't mess around with these compounds, because the bioavailability is an issue, and it's such a small amount to begin with that small changes can have a big impact. All right, next question. Why would you be concerned if your cholestyramine were added to your Aunt Georgia's medication regimen? Well, cholestyramine is a bile acid sequestrant, so it could bind the drug up and decrease your bioavailability. What is going on? The other big problem is that thyroid is enterohepatically recirculated, and that's really what I wanted to get at. Since it's enterohepatically recirculated, it's spit back out into the bile, which then goes back into the GI tract, and the cholestyramine is going to be waiting there to bind it up. So what's going to happen is you're also going to see a decrease in bioavailability and an increase in the clearance because of the enterohepatic recirculation. If it wasn't enterohepatically recirculated, it wouldn't be quite as big an effect on there. So the colors, you needed to talk about enterohepatic circulation to get full credit here, because that's the key thing here, is that you understand that the thyroid is enterohepatically recirculated. What changes have the FDA required of the levothyroxine products in the last 10 years? Well, we know that actually back in the 80s, they had to all be retested for the bioavailability. They all had to reapply for an NDA. But in the last 10 years, they also had to show a smaller range of variability as far as the potency. So the potency specifications for levothyroid went from 90 to 110% of what the label was to 95 to 105, so just plus or minus 5%. So we narrowed it because it's such a small number to begin with, and they should all be in compliance at this point. So you should have said something like this to get your point on that. So hopefully this is all clear to you now, and if you have any questions, of course, you can email me or come see me, whatever works for you. Thank you for working hard to learn this material for your patients. Bye-bye.